Hello, overcomers, and welcome to this episode of Connect Over Coffee. I am Runsi, the founder of Overcome, and today we are joined by a very special guest and a very special friend, Dr. Anil Sood. As you can see, is he all glory of ovarian cancer and Overcome with all his T-shirts, his background. He's ready to go. So thank you, Dr. Sood. And so in terms of introduction, so Dr. Sood is professor and vice chair for translational research at MD Anderson Cancer Center. And as an oncologist, surgeon, and a global expert in ovarian cancer, Dr. Sood is a scientist focused on converting lab discoveries into novel therapeutics. He is also the co-leader of the Ovarian Cancer Moonshot Program. So we have several questions to ask and several things to learn from Dr. Sood today. So join us for the next 45 minutes to an hour. I hope you have your coffee because I have mine. And there we go, he has his. And so we'll chat with him about all things ovarian cancer and also the advancements that are happening in the research space for ovarian cancers. And also, if you have any questions as we go along, please type in the comment sections below and we'll get it addressed post the discussion. So with that, a huge welcome back to you, Dr. Sood, to this episode of Connect Over Coffee. Always such a special honor to have you with us.
Thanks so much, Runsi. And boy, what a great series. You know, I was just looking through all the recordings you've done. Really pretty impressive. So really great job in putting all these together.
Yes, and we will be 100 episodes strong in 2024, so which
Wow.
is a big milestone for us. So thank you for saying good things about this series because we are pretty proud of it. So Dr. Sood, in terms of 2024, what should we be hopeful for or about when it comes to ovarian cancer in 2024? And if you were to pick the three most exciting advances in ovarian cancer that you see unfolding in 2024, what would you share with us? And what should our overcomers know about their promise in advancing treatment for ovarian cancer?
Yeah, it's a really exciting time in terms of all the advances that are being made, and the pace of discovery and new treatments is just incredible at this point. You know, I think that that there really are going to be, I think, a lot of new things coming about. But if I had to think about, perhaps three or four things that are on the horizon that continue to look really promising. Among those, I think new treatments and new drugs and new combinations certainly are, is a space where there have been a lot of major advances. Among those, I do think that that drugs that especially involve antibodies and what are called antibody drug conjugates, boy, what an exciting set of developments that have come about. And I do think that in the next year and perhaps even beyond, we're going to see continued development there. The most advanced among the antibody drug conjugates is the drug called mirvetuximab. The brand name is Elahere, and it's a drug that targets the folate receptor so that the treatment can be given in a much more specific way. And I think that that's just one of those such drugs in that class. There will be many others, I think, that will follow. And given that the proof of concept has now been established that this class of drugs can show promise for cancer treatment, I just think there's going to be a lot more investment in this space, as well as new drugs that continue to come out. You know, you'd asked for three, so I think a second thing that I think we really need, and I do hope that this really accelerates during 2024 and beyond, is that we need better and improved clinical trial designs and paradigms. You know, the traditional way of drug development has been fantastic, and it continues to have a major place. But I think we need more efficient clinical trial designs where we can accelerate the pace of testing the drugs as well as getting those approved. And among those, one of the trial designs that I'm particularly excited about is something called an adaptive clinical trial. And we've been working, it's really a national group that's been working together over the last about 2.5 years to design this. And now we're really waiting for engaging one of the companies to come on board so we can launch this effort. And our hope is that 2024 will be the year when this gets off the ground. And there are two major components to it. There's an upfront maintenance component, and then there's an arm that's designed for patients with platinum-resistant relapsed ovarian cancer. And again, the power of this is that this is a perpetual clinical trial, so it's ongoing. But the different and there's a control arm that continues to enroll patients. And then the treatment arms can open and close at different times, so they're staggered. So there's a lot of efficiency. And given that there's a single control arm, the ability then to open and close the different treatment arms is certainly a lot better. And so we're really excited about this. There have been similar trial designs that have been launched for patients with breast cancer, and even those with brain tumors as well. And those are well underway at this point. So I feel like that for patients with ovarian cancer, we need such a design that helps us accelerate pace of drug development. And then if I had to choose a third, the third would be perhaps a combination of things, which is that our ability to understand ovarian cancer in greater and greater depth just continues to evolve massively given the new technologies that are coming about, especially related to something called spatial analysis, where we can really look down at the single cell level and understand the relationships between cancer cells and the surrounding cells. And then, this thing called AI, or artificial intelligence, has gotten a lot of hype, but I do think that it's going to find its place in terms of should it be used for certain types of clinical decision making? Can it accelerate the pathology diagnoses? Can it help accelerate new drug development and make those drugs available faster to our patients? So I think we really are at a point where we're trying to figure out what's the right place for AI, and how can we use that much more efficiently for ovarian cancer and so on.
Such a fantastic summary. Thank you, Dr. Sood. So just as a follow-up on the first point that you raised on the ADCs, right? So you said there are many more, to come in terms of options. So as I understand that ADCs are only efficient when it comes to the folate receptor alpha patients. So when you talk about the more versions of the ADCs coming forward in 2024, do you think it'll have a broader significance in terms of inclusion, or is it going to be similar to what we have today? That's my question number one. And then question number two on your AI, because you sparked my interest there. Because it's important to realize, I think, that AI in itself is not a bad tool. It's only how we use it that will determine whether it becomes bad or an inefficient or an efficient tool. So in terms of diagnosis, you talked about some aid from AI, and also to me, I feel like when we come to personalized medicine, AI may be able to enhance what we offer our overcomers in terms of treatment options, in terms of specific medications or lifestyle, even guidance. So talk to us a little bit about these things, like,
Sure.
Yeah.
Yeah, no, very, very timely questions. I think the ADC that's aimed at folate receptor is literally just a starting point. I think there's a lot more that can be done. There are ADCs that are well underway for clinical development that target something called HER2 that's been historically particularly relevant for patients with breast cancer. But having said that, the early clinical data so far would suggest that these ADCs that target HER2, it may not it may not matter what kind of cancer they have, particularly among gynecologic cancers, but rather whether or not the target HER2 is present on the cancer cells. So I think that we're certainly going to see that. There are other ADCs aimed at TROP2, tissue factor. So there are many, many ADCs. And not just that, I think there are other targets that we haven't even fully discovered yet against which the ADCs can be developed. Another important advance I think that we will see in the next year or 2 years is that historically we were a bit limited in terms of what drug could be attached to an antibody because the types of linkers were somewhat limited. Well, that's being advanced now quite a bit so that the diversity of drugs that can be attached to the antibody is going to be much greater. And that will, I think, further afford better design of ADCs that can then be brought into clinical testing and then hopefully get registration and so on as well.
Great.
Yeah, and then with regard to AI, you're absolutely right. I think that it's how it's used and what purposes it certainly varies a lot. I think that among the broader population, perhaps ChatGPT is what people relate to in terms of AI. But boy, I think there's so many other applications. We know that just as an example, and this is not something that's ready for prime time by any means at all. We know that the pathology diagnosis, for example, can vary depending on if it's somebody with major expertise in gynecologic cancers versus somebody who does broad pathology. And there's some studies that would suggest that, for example, with certain types of rare tumors, the likelihood of misclassification is a lot higher if you just look at general hospitals and so on. Well, how do we improve upon that? And I do wonder whether AI-based systems could be one such strategy. And that's not to say that will replace pathologists, but not at all. But rather, could they help supplement the eyes of a pathologist in terms of making the diagnoses much more accurate? And we now know that the selection of treatments is only as good as the diagnosis that's made on pathology. So the more accurate the diagnosis can be, the better off I think our treatment algorithms and so on will be. Another example is imaging, whether it's CAT scans or MRI scans or whatever they may be. The resolution at which they're conducted and who's looking at them and with how much care can vary. We know that. And again, if AI algorithms or approaches, again, it's not that that we're asking that I think that we're going to replace radiologists, not at all. But rather, I think these kind of technologies can help hopefully supplement and make the diagnoses, picking up recurrences, picking up the sites of recurrence or the sites of disease much better than a human eye can do. Boy, that would be an incredible advance. In other places, we know that the rate of testing, the molecular testing for cancers is accelerating. And we know that a lot of the cancers do get tested. Mm-hmm. Well, once you get the results, an oncologist, especially, in community settings, may or may not know, okay, well, what are the newest drugs that are coming about, or what are the clinical trials that you may be able to pair that? What if we could design AI systems that could help screen through such testing results and rapidly come up with opportunities, hopefully both geographically as well as at a national scale, so that we can make access to care better for those patients as well. And those are, again, just a few examples. I can think of so many places where AI-based systems could really have an important place in oncology, especially for patients with ovarian cancer.
Yes, absolutely. Thank you for that hopeful message. And from moving from hopeful to challenges, right? So my next question was, yes, there are lots of, exciting advances happening in this space, but what are still some of the challenges and critical questions that still remain in ovarian cancer today?
There are quite a few. And again, just for discussion, we'll we'll address a few of them, but that's not to say that others are not important. But rather, these are some of the things that really I think are important challenges that I think we can hope some we can overcome in a near-term basis. Some will require longer-term efforts. So perhaps in the latter category, in the longer-term category, is early detection. It's a clearly a desirable goal, but are we there? And do I see it, being solved in the next year? Likely not. It's a really important but very difficult challenge to tackle. And there are many reasons for that. As we continue to understand the biology of this disease, there are many opportunities, but we also know that the incidence of ovarian cancer is declining over time, especially in the US and some of the Western countries. So in a disease type that's decreasing in incidence, then the early detection tests have to be even that much better for them to be reliable. And then the other challenge is, how do you scale these? How do you make these widely available? So that's one. The second is,
Dr. Sood, I'll interject just one thing here on the early detection thing, right? So I'm looking at it on two levels: early detection before diagnosis, early detection for recurrence, right? So now we know that, to your point, the early detection for diagnosis, it's still far, we have some ways to go to get there, early detection. When it comes to picking up the ovarian cancer returning, that is also sometimes, the detection timing is very important for the welfare of the patient, right? So would you say, in terms of early detection in ovarian cancer recurrence, we have reached where we need to be, or do you think we have more work to do there?
Yeah, let me answer that question in two ways. One is that, there are certainly opportunities for detecting recurrence earlier and earlier. That can include circulating tests, including circulating nucleic acids or exosomes or extracellular vesicles, improving imaging techniques. So there are clearly a lot of technologies that are evolving that I think can be deployed. I think the harder question in some ways, though, is that, okay, if you pick up somebody's relapse early, what can you do that would be clinically meaningful? So, and let me elaborate on that. So, so far the studies would suggest that, say if you have a patient whose CA125 is clearly rising, we're worried about relapse, but imaging doesn't pick up anything, right? So far, one of the large-scale studies that was done would suggest that if you intervene with chemotherapy or whatever treatment, when the CA125 is rising, compared to waiting until something shows up on imaging, the ultimate outcome for those patients is really no different. And if anything, sometimes you end up, adding more toxicity because you started treatment so early and so on. So, but that doesn't mean that we can't get there. Now, to your question earlier about one of the major challenges, I think, improving immune therapy remains a major challenge. We know that the immune system is important, but this cancer is just very difficult in the context of the presence of immune cells and how to improve immune therapies. Doesn't mean that it can't be solved. I do think that it can be improved and it can be solved. That also goes back to your second question, which relates to, well, what if you pick up cancer even earlier and earlier? Boy, if we could get to a point where we can improve, immune therapies, perhaps in the upfront consolidation or in the maintenance setting, those could be introduced. Or if we pick up the cancer early and we can introduce, new cancer vaccines or other new types of approaches, perhaps that could be more clinically impactful. And I think that's what's really needed, is that, okay, if we pick up somebody's relapse early, this is what we would want to do so we can improve their ultimate outcomes and so on.
And I feel like this is where also AI could be brought in for a lot of additional, if AI could have a supportive role in potentially figuring out what kind of treatments or things of that nature could be executed for that particular patient. But you bring up such an important point that, even if you pick up early, the cancer coming back, there isn't much difference in the overall results for this patient in terms of the treatment pattern. You could potentially, I don't know, even increase the toxicity for the patient with additional rounds of chemotherapy. So these are all good things to keep in mind when we talk to our providers as well, in terms of pushing for that early detection. So thank you. So frontline therapy, frontline maintenance therapy, I wanted to ask you, how is that evolving in ovarian cancer, and what is its role in keeping the cancer at bay, and in which setting would you not recommend it? And what should our overcomers know and ask of their care team about this, the evolving role of frontline maintenance therapy?
It's certainly an incredibly important space where we need to continue to do better and better. Now, one thing I'll qualify it is that, ovarian cancer, as I think most people know at this point, it's incredibly diverse cancer type. There are many, many, many different subtypes. So I think when we talk about maintenance, right now, it's predominantly for those patients who have high-grade serous cancer, perhaps endometrioid subtypes, and certain other subtypes of cancer. There are that's not to say there aren't maintenance options for those with less common subtypes. There are, but I think for this discussion, perhaps we'll focus more on the high-grade serous part for now. So in the early 2000s, there were clinical trials that were done that looked at using chemotherapy, so paclitaxel or Taxol for maintenance. And, it showed some initial interesting data, but that didn't really pan out. And we know that chemotherapy on an ongoing basis can certainly have its side effects and so on that can be difficult to address. So now, over the last several years, what we've learned is that those patients who have a germline mutation in BRCA1 or 2 or related genes, or who have a tumor-based mutation in those genes, or have something called HRD positive cancers or homologous recombination defects in the tumor, then PARP inhibitors have certainly been, in my view, game changers for upfront maintenance. And those are, I think, heavily used in that kind of a setting. And the data have been just very consistent in terms of improving, especially progression-free survival of patients with ovarian cancer with those drugs. Now, patients who have homologous recombination, what are called proficient tumors, or whose tumor doesn't test positive for HRD, even though the PARP inhibitor does carry a label in that setting, the magnitude of benefit is less clear. It's really quite minimal in that setting. So most oncologists tend not to necessarily use PARP inhibitors in that setting. Now, drugs that target angiogenesis, and I know we talked about this a little bit in the past, so bevacizumab that targets the blood supply to cancer, that's certainly approved for upfront maintenance as well. And as we continue to learn about what are the appropriate roles for it, perhaps the more important role for that drug is in patients who have higher risk disease, meaning those who have particularly advanced cancer that may have spread to other organs like liver or lungs and so on, or who have residual cancer after their surgery, may be the ones to benefit more from using bevacizumab for a maintenance setting. Now, the other question you brought up is, who are patients perhaps who may not be the best candidates for upfront maintenance? And, this is not an absolute answer, but it's what we're considering is that perhaps patients who have a really good response to therapy upfront, who have no residual cancer at the end of surgery, and their cancer is, it doesn't have HRD or it's homologous recombination proficient, whether or not those patients benefit from bevacizumab is less clear. And that's a setting we'll have a discussion with the patients and perhaps not use maintenance currently. But, as I mentioned earlier, in this adaptive clinical trial design, we feel that there are opportunities for improving maintenance strategies. And that's the reason why one of the major components is a maintenance arm for that adaptive clinical trial, especially for patients who have homologous recombination proficient ovarian cancer. And the kinds of drugs, again, that can be positioned there, or the combinations, are certainly quite a few, including ADCs that we already talked about, including some of the immune drugs that are coming about, as well as other antibody-based treatments. So really are a lot of opportunities that we can develop in that space.
Wonderful. Thank you, Dr. Sood. So you are also the co-leader of the ovarian cancer moonshot program. So tell us a little more about this program. What are the key vision areas for you and that you and your team are addressing, and what should our overcomers know about the new knowledge and hope that this effort is to bring?
Yeah, thanks. This effort has now been going on at MD Anderson for about 10 years. And there have been many programs that we started as a part of the moonshot that have, quote, graduated, meaning that they just became routine part of care. So they didn't necessarily need to reside within the umbrella. And I'll just give you a couple of examples. When we first started, our decision-making around who should have surgery up front versus who should receive chemotherapy was a bit arbitrary. And so we implemented laparoscopy as an approach to make much smarter decisions about who should or shouldn't have surgery up front. And that I feel really proud about that our group was able to implement that consistently. And so our compliance rates have been incredibly high. And that's a program that graduated from the moonshot, because that's just now routine care. And so now for patients who do go to upfront surgery, the likelihood of removing all visible cancer approaches 90% compared to before this program, when it was only about a third of the times that we could do that. So again, I feel really proud about that particular implementation. Another aspect that I think has been at a broader level, has, I think, been such a success, is that historically genetic counseling and testing rates were pretty low, both at MD Anderson and around the country. And that was a major effort that Dr. Liu helped to really champion and implement in our moonshot. Within 1 year, our testing rates exceeded 80%. And so within a fairly short period of time, that just became routine part of care. And now, that's still done. Now,
so Dr. Sood, when you say 80%, you are speaking of Anderson only, or is it nationwide right now?
Well, that was at MD Anderson. So that was a nationwide. And nationwide, the rates continue to improve, but they're not still
not there yet.
No, still not there yet. And moreover, another really important part that does continue to bother me is that in underserved communities, the testing rates are way low. They don't even approach 20%. So I do think that there's a lot of work that needs to be done. But again, if you were to ask me, I do think it's a solvable problem. I do think that it's scalable, so we can do much better. So I just wanted to give a couple of examples about how the moonshot effort has evolved. The current major 3 projects that are a part of the moonshot is one is to improve immunotherapy. And we're working with Dr. Jazeri and with Dr. Rizvani. We're really excited about something called CAR NK cells. We think that this particular approach is going to be far better than CAR T based approaches, especially in terms of scalability and in terms of the potential for side effects and even effectiveness and so on. It's a much longer discussion that at some point I think we should hold, but really excited about that. And there's a lot of other work going on in the immune space in terms of understanding mechanisms of immune suppression, how to improve immune therapies, and so on.
And
And
I'm sorry for asking so many questions, but
sure.
you're bringing up such interesting points that I cannot hold myself for the immunotherapy, the work that you're doing. I'm assuming including the sensitive as well as the resistant overcomers, right? Both groups.
Oh, absolutely. The current clinical trial focuses more on patients with platinum-resistant relapse cancer, but that doesn't mean that it can't have applications down the road for those with platinum-sensitive relapse. Of course it will, but that's just a particularly an area of particular need right now. So that's a reason some of the initial clinical trials focus in that space.
Makes sense.
The second project is that, as I mentioned earlier, we know that drugs that target the blood supply, so bevacizumab, clearly has a major role, and it's used a lot for patients with ovarian cancer. But we know that after a certain period of time, the cancers adapt and they start to grow despite this treatment. We've made an observation that there's a metabolism pathway, particularly around an enzyme called glutaminase, that seems to play a role in how tumors adapt to this drug. So we did a lot of preclinical work. One of our clinical fellows, Dr. Glassman, she actually helped champion this work and really came up with a combination where a new drug that was developed at MD Anderson called a glutaminase inhibitor is then combined with bevacizumab plus chemotherapy. Really effective response rates in preclinical studies. And so Dr. Tim Yap and Dr. Shannon Weston helped us to bring that into clinical trials very rapidly. That clinical trial is open, and we're continuing to enroll patients in that. The very early data look really exciting, and we want to obviously enroll that clinical trial as quickly as possible so that we can advance that combination further. And there are many other drugs or opportunities for improving the effectiveness of bevacizumab. So it's a large area that I think continues to evolve. And one of the targets that we identified recently is called CD5L. In partnership with Dr. Zhishang An, we developed a new antibody against that we're trying to bring into clinical testing as well. So again, a lot of space. The third major project is that, while the PARP inhibitors have been incredibly exciting development, we know that if they're used, especially in a relapse setting, there are patients who can develop secondary cancers, particularly a type of leukemia called AML, and another condition called MDS. And these can be deadly conditions. So we felt that it was really timely to launch a project that helps us understand, why do some patients develop this? What can be biomarkers that can give us early clues on who might be at risk for these kind of secondary cancers? Maybe there are patients where we shouldn't use PARP inhibitors, who are particularly at risk for these kind of secondary cancers. Then the third thing is that, once this type of leukemia develops, it's deadly. And so we're also working with our leukemia colleagues to figure out, listen, are there better treatment approaches? The traditional approaches for leukemia don't work so well in these secondary malignancies. So we're trying to also figure out what are the other opportunities for new drug development in that space. This is an early effort, but I do think it's a very timely and important area that we need to address, so that we don't cause a second problem, as we use these kinds of drugs and so on.
That is very significant. Thank you for sharing this with us, and especially particularly the point that if there's a way for us to determine which patients will not benefit from PARP inhibitors and maybe even at risk of developing secondary cancers, that saves so much of time, effort, resources, everything, and health, most importantly, for our overcomers, right?
Absolutely.
So, very, very important point. Thank you. I have to ask you about stress hormones, because all guests and everywhere, they talk about you, they talk about your work on stress hormones. So tell us a little bit about, your research on the effect of stress hormones on the ovarian cancer growth and progression. I've asked this question to you multiple times, but it's cited by so many physicians and scientists that collaborate with you, that we want to know more about this. And also, do you see in your work, have you seen any established linkages between depression, anxiety, or mental disorder and the growth and progression of ovarian cancer? And what is the key takeaway of this study that our overcomers should know of?
Thanks. First of all, I just want to mention that anything I do, I have been just incredibly fortunate to have a network of collaborators who've just been just so helpful and in terms of driving these different areas. A lot of the work, and I know you've had her on an episode previously, but really a lot of this work for me started when I worked with Dr. Susan Lutgendorf from University of Iowa, which is where I did my fellowship training and so on. And she's just been an incredible collaborator at this point, for 25 plus years that we've been working in this area. It's an area that when we started working in it was considered soft science, and a lot of the quote hardcore scientists would sort of would not have a positive view of this kind of an area. But now it's just so rewarding to see how this field has evolved, and that it's okay for people to talk about the effects of stress on different diseases, including cancer. The second point I would just make is that when we talk about this field, stress can be really adaptive. So acute stress, that we face as a part of just our day-to-day lives, there's nothing wrong with that. That's actually incredibly adaptive, and that's a part of how we function, and that's a healthy part of our stress responses and so on. But just like with a lot of things, too much of something can be bad, and so chronic stress is really what we talk about in the context of making disease or cancer worse. So in the context of many of the different facets of stress. So by the way, for a psychologist like Susan Lutgendorf or Dr. Lorenzo Cohen, who I think you've also brought on this episode before, stress is a catch-all term, and some of the specific terms that you brought up, related to depression and so on, I think it's important to address. So what we see are that, technically, depression is actually not a part of necessarily the stress paradigm. But having said that, those with long-standing depression or major depression, a lot of the cytokines or the pathways that get activated in their bodies are very similar to chronic stress. And so we do see relationships with depressive scores or high depressive scores and patient outcomes. And that's been shown. So Dr. Susan Lutgendorf showed that in patients with ovarian cancer. Lorenzo Cohen showed that in patients with kidney cancer. And so there are many cancer types where we see that. On the exact opposite spectrum of chronic stress is something called social support. And that's the extent of network around people that they have access to. And the higher the level of social support, the more protective it is. And that's, again, been shown very consistently across different cancer types. So Susan showed this in patients with ovarian cancer, that it actually relates to patient survival or patient outcomes. And other groups have shown that in patients with breast cancer, kidney cancer, and so on as well. Now, anxiety specifically, there isn't really great data to show that that portends poor outcomes and so on. So I do think that it's important to understand, which aspects of these biobehavioral pathways do or don't relate. Another part of this is that, okay, now that we are starting to understand this biology at so much deeper level, what can we do about it? Susan and some of the other groups around the country have championed biobehavioral interventions. A person named Michael Antoni at Miami, he's championed something called CBSM, or cognitive behavioral stress management. There are pharmacological opportunities, such as with beta blockers or with other medications that perhaps even combinations with anti-inflammatory drugs that may work in this setting. A really exciting clinical trial that was done at Roswell Park with a beta blocker plus immunotherapy in patients with melanoma showed striking results in terms of response rates and so on. Those kind of studies, I think, are really where we need to move to and test, do these kind of interventions matter and so on. Many years ago, we found out that that ovarian cancer and other cancers do actually have nerves that can mediate perhaps some of these kinds of effects within the cancer and so on. And initially, again, a bit controversial, but now, after Susan and I and others actually championed this biobehavioral research network through the NCI actually put money into studying the role of nerves in cancer and so on. So it's really interesting and rewarding to see how this field has continued to develop and evolve further. A lot still needs to be done.
Yeah, and also I feel that it's so important, to your point, that we do not ignore these, these situations or circumstances that many times we do get so clinical about the disease. But again, I'm a big proponent of overall health being mental and physical. So it's so important that we understand the intricacies between the two and give them equal importance, not just in cancer, but everything in life, right? So thank you for highlighting that for us and our overcomers. Appreciate that. So now, your research interest, I mean, you are a physician, you are a surgeon, but you are also world-renowned researcher. So tell us about, you've talked to us about your Moonshot program, but some of the other things that you are interested or your lab is working on. What is your primary, areas of research interest, and how do you see them evolving in 2024 and beyond?
One of the interests is really relates to what we started to discuss earlier in terms of targeting the blood supply to cancer. Yeah. I still feel like there's so much that can be done. So we have members of our group who are working on identifying new targets for therapy in that area in terms of better strategies for targeting the blood supply. And one of those is called EGFL6, that similarly we've developed a new antibody that's a part of our SPORE grant mechanism. And I know you're actually really helping us with as an advisor on the SPORE and so on as well. Still a lot of work in terms of understanding how cancers adapt to this class of drugs, and in developing then strategies to delay this adaptive resistance or overcome that once it does show up. Where I do think that we need to understand how this cancer spreads to a much greater extent. Historically, most people used to think that this cancer just spreads from surface to surface. I just don't think that it's that simple. We know that, when we do surgical staging or when we do imaging studies, there are a lot of patients who have spread into the lymph nodes, into other organs, and so on. How does it get there? How do we understand the biology better so we can be smarter about intervening or preventing the cancer getting access to those kinds of places and so on? So we have a doctoral student who is really doing incredibly exciting work in that area that I'll hope to share in more detail, at upcoming discussions and so on. We're doing a lot of work in terms of new biomarkers, and especially around what were called exosomes, but now they're called extracellular vesicles. Those, I think, we can actually even engineer for therapies and so on. So one of the lab members, and this was a completely unexpected area, that we discovered that actually plants make similar vesicles. So we now have a whole effort in collaboration with a plant geneticist at Rice, Dr. Janet Bram, where we're trying to engineer plant vesicles for cancer therapy. So they're plants that have, really beneficial compounds in their own right that are anti-inflammatory and so on. But others we can engineer where we can put drugs of interest into vesicles that we can then deliver. I find this exciting because, we consume plants on a daily basis. And with the exception of, certain things like peanuts and so on, where their allergies are more common, there are a lot of plant species that we consume quite safely and on a large scale basis. So I think that that I really do want to push on that in terms of developing that further. And then, we have members of our group who are doing the kind of studies that I alluded to earlier, really in-depth look at ovarian cancer in terms of spatial analyses, both at, at RNA, DNA, protein, metabolism, multiple levels, so that we can be so much smarter about new types of treatments and so on. So those are some of the areas that we're really excited about, that I hope that we can make major advances in.
Thank you. And like you said, we'll have to bring you back when, as you evolve with these studies to learn more about what's happening. So now just switching gears to surgical advances, right? Because you're also a surgeon. So I recently was reading that the study has established that aggressive upfront surgery helps in extending progression-free survival in ovarian cancer. Tell us more about your thoughts on this, and also on your thoughts on second look surgery, because I'm seeing the second look come up in articles more and more than before. So talk to us about that.
Yeah. As far as the surgical resection of ovarian cancer up front, we've known for a long time that if we can remove the more cancer that we can remove, the better the outcomes, particularly if we can remove all visible cancer. The harder part is that a lot of our patients also have a number of other comorbidities, and some of our patients are quite elderly, where so it becomes a balance of what's the right approach that you can do in the safest manner for a given patient, right? If we do a really aggressive surgery and the patient doesn't make it out of the hospital, I consider that a failure. I don't think we help that patient at all. So I think we need to be really smart about those strategies. And this is why I alluded to that. I'm really excited about the algorithm that we were able to implement with laparoscopy, and being smart about who we operate on for aggressive surgical efforts and so on. It's clearly important, but not everybody can and should have that kind of an effort and so on. So I think that kind of an algorithm, and that'll continue to evolve. I think perhaps imaging will improve. Perhaps with AI algorithms, it'll evolve further. Perhaps there will be other markers that will replace laparoscopy. So there are many opportunities still, in that area. Another aspect of surgery that I think is an area that's going to develop quite a lot, I think, in the next 5 years, is that at times, when we give chemotherapy, for example, in an upfront setting, meaning neoadjuvant chemotherapy, and then we do surgery, boy, during the surgery, at times it's hard to tell what's scar, meaning, quote, burned out tumor, versus what's real viable tumor. Differentiating the two isn't always easy. And, if somebody has burned out tumor where there's no viable tumor, you don't want to go crazy trying to remove all those areas either. So we want to be able to, in essence, in real time, try to figure out what are the areas that we really need to go after. So Dr. Nicole Fleming is leading a surgical study here, where we use something called a mass spec pen that was developed by Dr. Livia Eberlin, who's a very close collaborator. And this pen, within minutes, can give you a metabolic profile of, and help distinguish, hey, does this really look like scar, or does this look like cancer? It's also being tested in a brain tumor setting as well to determine margins and things like that. So, it's in a trial right now, so we don't know how well it may or may not work. But I do think that that's a kind of a surgical space where there's opportunity for innovation. Absolutely. Now, with regard to your question about second look, when I was in training, we did lots of second look surgeries. In those days, they were done through a large incision. And around in the late 1990s, we stopped doing those because there was really no benefit for patients, and it clearly can have risk with it. Well, in 2024, it's a different time. Such surgeries can be done, through a minimally invasive route. So Dr. Jazeri is helping us champion that. And I think you've also had him on such discussions, so that a lot of these surgeries can be done now laparoscopically, where we can take tumor samples and be able to do an in-depth analysis of those samples to figure out, hey, why are some cancers persisting at such a microscopic level and so on. Second thing is that, compared to the 1990s, we just have so many new and different drugs now. Now, do I know that they're going to work in this setting? Of course not. But I think based on second look assessment, whether it's immune therapy or some of the targeted therapies, or perhaps based on knowledge from testing the tumors, the right kinds of drugs or ADCs, there's just so many opportunities now for testing drugs in that space. So I do think that it was time to revive the second looks assessment. Again, we don't know yet whether this will have benefit for patients, and we always have to keep that as our center focus. That we want to do things to help patients, and that's why we're doing things right now as a part of trial testing. In the long run, we would love to see that become a routine part of care.
Absolutely. Overcomer at the center of it all, right? So that's what our focus always is. Now, you have imparted so much knowledge to us today. So let's get to know who Dr. Sood is a little bit, switching gears. So outside of that lab coat, what should our overcomers know about you that they would most resonate with? And how do you overcome your own challenges?
Yeah, no, thanks for asking that. I think the first point that I would make is that, cancer is something that affects pretty much all of us, either directly or indirectly through our families and so on. My father died of a very aggressive form of prostate cancer, and that had I know your mother passed away from ovarian cancer, and for me, that had a major impact in terms of bringing research into my own career, with really a goal of trying to improve cancer therapy. And so, and I do think that that'll resonate with many people, because it affects so many of us in direct and indirect ways. I think the second point that I'll make is that, for me, how I handle our day-to-day stresses or doing things, physical activity, which I think is so important, and it doesn't have to be anything crazy. We know for patients with cancer, 15 to 20 minutes of walking a few times a week can have a huge impact, in terms of many aspects of their care. For me, exercise has just been a really important part. And so I took up running again, and this year my plan is to run in the Houston Marathon. And this year, I'm going to work to raise money for the American Cancer Society, and I've requested you to get listed as a part of the Houston Marathon. So next year and beyond, we can work toward raising support for Overcome as well. But that's really an important part. That I enjoy exercise, but I also, if I can take advantage of it for raising money for efforts such as Overcome or American Cancer Society, I enjoy that even more.
Absolutely. Thank you very much. And so, if you could change the tomorrow for ovarian cancer, what would you do, Dr. Sood?
Oh, there's so many things. I detected early, I prevent it altogether. And that would be really powerful. I would improve treatments along the many areas that we talked about, and very importantly, not to forget about this part at all, is that I would also improve survivorship, meaning reducing side effects of therapy, and also help not only patients with cancer, but also their families as well.
So I have asked you a lot of questions, Dr. Sood. What have I missed asking that you would like to share with us?
I think you've really covered a lot of things, and if we missed anything, we'll
come back, right?
I'll just have to come back.
Yes. So just in closing then, I know we are getting to the top of the hour. So what message of overcoming would you like to share with our audience?
I'd like to share a message of hope, and I think I mentioned this in the past as well. We know that, in the last 20 years, the incidence of ovarian cancer continues to decrease, but and also we know that the prevalence, meaning the number of patients with ovarian cancer who are living, continues to expand, and we know that the overall survival outcomes we are making progress in, and that's improved substantially over the last 20 plus years. That doesn't mean we're done. It doesn't mean that we're curing more patients, and that's the kind of work I think that needs to be done. But we are making progress, though.
Thank you so much, Dr. Sood. This was a fantastic conversation. I know you have to run to your next appointment, so thank you for your time and your fantastic and valuable insights that you shared with us today. And overcomers, I know this was beneficial for you. I mean, as I always say, we keep learning from these fantastic and knowledgeable experts that come to us and share their time and their knowledge with us so freely, and we are so appreciative of that. So thank you for watching, and we'll be back for the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.
Thanks.